I am Sierra Emberson, and today is January 3rd of 2021. We made it. Happy New Year. Today, I am going to investigate two clinical cases that both outline how nitrogen-containing metabolites can inevitably cause substantial disease issues for the body. So we're going to look at nitrogen compounds that maybe don't make it to the proper final product, and how that's really important, since nitrogen is both a very good thing, but also can be a very negative thing. It just kind of depends on the form in which it takes. Nitrogen-based metabolism is incredibly interesting and important because it encompasses the synthesis and degradation of our proteins, our neurotransmitters, and even our very genetic material. However, when affected by disease, nitrogen metabolism can create these nitrogen-containing compounds that, when increased in concentration, can cause potentially fatal toxicities. So, looking at these two cases, our first is a female neonate with an acute crisis 24 hours following her birth. She's presenting with lethargy, apnea, hypothermia, and this certainly indicates emergent intervention and diagnosis, as this patient is very much in danger of going into arrest and is undoubtedly in shock. So a blood glucose test is warranted. Because if low, the supplementation for that low glucose, that hypoglycemia, could be instantly beneficial and potentially life-saving. And if that glucose is normal or even high, there are many congenital metabolic diseases that can be ruled out, such as beta oxidation deficiencies, because that's when we would expect hypoglycemia. So we really want to go ahead and make sure that we run that blood glucose test as soon as possible. It can be assumed that the liver is having appropriate gluconeogenic responses to epinephrine and cortisol, especially because in response to this body's attempt at self-revival, if it is in a critical state. So it can let us know, a normal blood glucose can let us know that other things are actually functioning as they should in response to how this patient's body is experiencing being compromised. Likewise, with a normal blood glucose, oxygen support, heat support, and fluid support could potentially stabilize this patient until a diagnosis is made. So, now, another differentiating test may involve assessing glutamine levels. We don't want to negate how important glutamine level is, because glutamine and alanine are amino acids that carry nitrogen safely in the body. And remember, we are discussing things about nitrogen today. So as the plasma levels of ammonia, and we'll get into why in a bit, but as plasma levels of ammonia rise, this can activate glutamine synthetase, and more glutamine is made, utilizing and kind of diverging this ammonia into a safer compound. So that being said, elevated levels of glutamine could very well support but not determine a urea cycle disease. And this would be another thing that we are really looking into with this patient. But just running a glutamine level would not let us know if this patient is in a hypoglycemic crisis. It would not indicate anything about metabolic disease such as beta oxidation deficiency. So now we do have some lab work that we got back. Okay, so we're gonna take a look at this lab work. Hey, assistant, come here. Can I see that? Can I see this? Come here. You want to give me this? Let me see. Oh, thank you. All right, so we have our lab work here that our assistant provided us. He's a very good assistant. This is Leonidas. He deserves credit. So, as we can see here, the ammonia levels of our patient are at a very high range. They are presenting at 314 but a normal range is 17 to 80, and they are rapidly rising. So this is a dynamic case. It is changing rapidly. We're also getting back a urine analysis on here saying that orotic acid levels are markedly elevated as well. My goodness. However, we are getting back, and we're investigating a lot of urea cycle at this point. We are getting back a normal citrulline levels. So we really need to take a look at why all of these things are intercorrelated. So I'm going to let you take a look at these things here. I'm quoting this right here from our lab work. So, alrighty. Thank you, Leo, for that lab work. So the most concerning element would be the extreme hyperammonemia. That would be the ammonia levels that we are seeing. So ammonia, which is NH3, is a naturally occurring compound resulting from protein metabolism and turnover as nitrogen. As nitrogen is a defining feature of amino acid structures, but it's also incredibly neurotoxic. So hyperammonemia generally causes neurological symptoms, damage to nervous tissue, and encephalopathies. That can definitely describe a lot of what we're experiencing with our patient. So the exact mechanism may be unknown, but as to why it's such a neurotoxin, but it is likely due to the combination of the alteration of neurotransmitters, the depletion of ATP, and the increases of glutamate causing cerebral edema, the altered mentation, and the encephalopathy. So the question we have yet to answer is, why is this patient experiencing hyperammonemia? It is very, very likely that this patient is experiencing a urea cycle disorder. So ammonia is converted to urea, which is a water-soluble compound. It's excreted in our urine by the urea cycle, by the kidneys, and it's made with the urea cycle enzymes. So now ammonia can build up if there is no way that urea can exit. So if there is no obstructive physical reason why urea can't actually leave our body, then a failure of the production of urea is definitely indicative of why we're experiencing the hyperammonemia. So while many liver-based diseases could inevitably explain urea cycle issues, this patient is a neonate, and congenital deficiencies should be on the top of our list of differentials. This is only 24 hours after after birth. The most common urea cycle deficiencies are hyperammonemia type 1 or 2. And in type 1, the regulatory enzyme for the urea cycle, carbamoyl phosphate synthetase 1, is affected, but with type 2, ornithine transcarbamylase, or OTC, is affected. So, sorry about that. We had a minor issue there. So 2 key factors that help decipher which enzyme is affected here. If the patient's age in the presence of the orotic acid urea. So the UA was such a key benefit to why we're actually experiencing these issues in our blood work. Type 2 hyperammonemia caused by OTC deficiency usually presents within 48 hours after birth. It's an X chromosome linked disease. So while this patient is female, it does typically affect males. OTC produces citrulline from carbamoyl phosphate under normal conditions. So we're going to take a look at this in our book here. So I'm taking this directly from our textbook. And so we're going to take a peek here, and I'm going to show you the urea cycle. Okay, so here we are. And if we look at this area right over here, where we have the mitochondrial and cytosol linkage, we have the first 2 enzymes that we've been mentioning. Our regulatory step, our very first step, and then our secondary step with OTC. And then we see that citrulline can actually be shuttled into the cytosol. So this is actually the process that we are investigating right now. So that being said, excess carbamoyl phosphate is shuttled into the cytosol if it cannot move forward with the urea cycle. So why does this happen? So that buildup in that mitochondrial and it is shuttled out. Now, what happens from there? Well, it's actually very beneficial for pyrimidine synthesis. So, the urea cycle, if it's blocked in some manner, deficient in some manner, and that carbamoyl phosphate increases, then we're going to have a lot of pyrimidine synthesis come from that because the body is trying to utilize that component, and excess of it is definitely going to activate that pathway's enzymes. So, if that's the case, then we're going to see an excess of orotic acid, which is a byproduct of pyrimidine synthesis. So the fact that this patient is experiencing elevation of orotic acid levels and in the urine indicates that we absolutely have an excess of carbamoyl phosphate. So that first part of the cycle is affected in some way. There is some backflow that is causing that to increase. Okay, moving forward. The most curious part of this patient's lab results would be the normal level of plasma citrulline. Since this is the direct product of OTC, one would assume that the levels to be low because OTC is affected, but diagnosing this case early enough would cause a reflection of the plasma levels that were closer to that at birth. So we're actually testing this at 24 hours after birth, and we can tell from the ammonia levels, the dynamic change of the hyperammonemia, that this is changing rapidly. And so we're actually going to predict that those citrulline levels are going to fall, that potentially we're going to see a low citrulline level at about that 48-hour mark. Even though OTC creates citrulline, it is not a diagnostic indicator of hyperammonemia type 2. But because we actually have the presence of carbamoyl phosphate and we have the evidence of it with the orotic acid, we know that that first enzyme in the process is functioning. So carbamoyl phosphate synthetase 1 is absolutely functioning, and we have 2 reasons to know that this is actually true. So this patient is going to be most likely going to be experiencing hyperammonemia type 2 or a deficient OTC enzyme. So ornithine transcarbamylase is the one that we would expect to be affected. So this is very interesting in terms of treatment. As long as we can narrow it down here, absolutely we can intervene with this patient and hopefully get them back to a more normal metabolic state. So, okay. Now we have another one to consider here. So as we continue, we're going to take a look at our second patient who helps us understand that who continues to help us understand how nitrogen-containing urine products are so important. Excuse you, bless you. Apparently I have a patient of my own in here. So our 47-year-old male patient, he is newly diagnosed with gout, and gout is characterized by hyperuricemia, or elevated plasma levels of uric acid. And this uric acid gets deposited in the joints, kind of ends up falling into there, and it causes pain, inflammation, and swelling. And under normal conditions, uric acid is soluble. It's excreted in the urine. So this is not the same, but a little bit relative to our last patient where urea was expelled in urine and we were able to dispose of excess ammonia in that manner. So back to this patient, uric acid levels are also indicative of cardiovascular disease. They're linked to lipogenesis and obesity. So there could be several reasons why this patient is experiencing a gouty arthritis. elevated plasma levels of uric acid, or urate as it is called at this stage, is either due to an overproduction of purines, which causes a secondary increase in purine catabolism, a decrease of purine salvage, or issues with urinary excretion. And in some cases, there are a combination of these main categories. So uric acid being a component of purine catabolism. So in their last patient, we were talking about pyrimidines, but now we are actually looking at purine catabolism. So if there's an